Good. Right. So, Rebecca, thank you for that. And let's move on to the Rainbow trial, of which I believe you are the national lead.
Yes, I am. Yeah. So Rainbow is the frontline study in the UK. So we've got lots of centres participating. It took a long time to set up. So the predecessor to Rainbow was R2W, which some of you may or may not have participated in. So Rainbow, as I say, it took a long time to set up. I can remember from the age of my son, because I was pregnant with him when we first started talking about Rainbow and applied to Janssen for ibrutinib from them. And he's now about to turn 7. It hasn't been open that long, but it was a long journey to get funding in place for Rainbow and to finally get it open just before COVID actually opened. But it's going really well, and it's great to see lots of enthusiasm for the trial in the UK. So what is Rainbow? So it's what we call a randomized phase 2/phase 3. So it's a 2-arm study, and the computer decides, once the patient is signed up and deemed to be eligible by their doctor, the computer decides which arm the patient gets. So it's a 50-50, so you've got a 1 in 2 chance of getting either arm. So what we call the experimental arm is the arm containing rituximab with ibrutinib, and that's being compared against a standard treatment arm, which is with dexamethasone, rituximab, and cyclophosphamide. And that's quite a standard way of running what we call a late phase study. So it's comparing your new treatment against your well-established, well-known treatment. So we've got 2 parts of the trial, and after a certain number of patients, we're going to be looking at the side effects and the early response rates that we see with rituximab and ibrutinib. And then the final assessment that we make in the when we've fully recruited the whole trial, we're going to be looking at whether what we call progression-free survival is improved in the experimental arm. So that's the length of time that you are well and without progression or without relapse of WM. On the study as well, we're going to be looking at some laboratory assessments to see if we can improve how response can be assessed. So rather than doing bone marrows all the time, can we just look at the blood to look at response to treatments, and also going to be looking at some genetic changes that can occur on the trial as well. So next slide. So we've seen this slide before. So why are we looking at ibrutinib in WM? And that's because of the MYD88 mutation. So we've already talked about it being present in pretty much everyone with WM, so over 90% of patients. And if we look at the next slide, so this shows us why we're looking at ibrutinib, because ibrutinib targets BTK, so it inhibits BTK. So if you could look at that picture there, you've got MYD88, which is the top part of the pathway, and that together with BTK makes sure that the WM cells don't die. So that mutation means that the BTK is overactive, the whole pathway is overactive, and it's preventing the WM cells from dying. So we know that inhibitors have been designed to BTK, and the first one that we know about is ibrutinib. And this binds to BTK and causes the cells to die by binding to BTK and stopping that pathway from being active, essentially. Next slide. So because of this, because of the importance of MYD88 to the WM cell, and because it relies on this mutation to grow and divide, this is the main reason why ibrutinib was looked at first of all in WM patients. And in the first instance, it was looked at in the test tube. So there were some cells, WM cells growing in the test tube, and ibrutinib was able to kill them off in the cells that had the MYD88 mutation. So that was the kind of laboratory background for looking at this combination. And then in 2015, Steve Trean published the first data for ibrutinib in relapsed refractory patients with WM, and it was from this trial that WM got its license in the US to begin with. And you can see from the results that I've shown there, this trial was really, really successful.
Sorry, I've messed that up. Hold on. Bear with me. Bear with me. What have I done? What have I done? Right, share screen. Bear with me a sec. Okay, just bear with me a sec. I've got to go back to the start. There we go. Right, so. Can you see that now or not? No? No.
No.
Share screen.
It's the one with a green square on, Bob.
Yeah, I know. I can't, even that's not
Oh.
coming up now. Yeah.
Right.
All right, hold on. I was trying to make it. Come on, come on, come on, come on. Right, share screen. Is that it? Yeah. Are we back? Yeah. Are we back? Yeah. Is that it? Can you see that?
Yeah, next slide, yeah.
Next slide. Okay.
So if we look at the reasons for running the study, so the first publication of ibrutinib activity in WM was in 2015 when Steve Trean published his data, and this, as I was saying, gave ibrutinib its license in WM. And you can see from what I've written there that the activity in relapsed and patients who had had lots of previous treatments was really impressive response rates, over 90%. And that the time on drug without any progression of the lymphoma or the WM was again really high at 69%. There was another study that was published called the Innovate study, and this was based in Europe. And in this study, they looked at rituximab and ibrutinib in combination and compared that with rituximab and placebo. And again, in this study, the rituximab and ibrutinib looked really, really effective. And not surprisingly, was much more effective than rituximab on its own. But there's no data yet. There's nothing comparing rituximab ibrutinib or ibrutinib on its own with what we call standard of care. So your standard rituximab immunochemotherapy that patients are prescribed in the frontline setting. So that was the main thrust for doing this study, is to see the to see the difference between standard of care and rituximab and ibrutinib. We know from our previous studies that these trials in the UK are very popular, and that it was perfectly feasible to run a study like this in the UK because we've been very successful with R2W, and the trial that preceded that was called WM1. So next slide. So this slide shows some of the results from Steve Trean's data, where they've looked at outcomes with ibrutinib depending upon mutation status. So Steve Trean's looked at this in a lot of detail, and if we just look at the bottom lines on the slide, so in the first group of patients with a mutation of MYD88 and what we call wild type, so no mutation in CXCR4. Patients did very well on ibrutinib from the study that he ran. We look at the next line down. Patients who have a mutation in MYD88 but also have a mutation in CXCR4, they don't do quite as well. They still do well with a progression-free survival. So that's how we're measuring the how well patients do at 42 months. And then if we look at the bottom line, those are what we call wild type. So no mutation for MYD88. And no mutation for CXCR4, which is only a very small percentage of patients with WM. They don't tend to do so well with ibrutinib. We don't know yet how these mutations pan out in patients to get rituximab chemotherapy, actually. So although this has been done in patients treated with ibrutinib, it hasn't particularly been replicated by other groups of people, and it hasn't been looked at in patients who are just getting your standard rituximab chemotherapy. So this is quite early data yet. So in our study, we're still letting patients in, irrespective of MYD88 mutation status, and we are going to be testing everyone. So we're taking samples from everyone at trial entry and looking at MYD88 mutation status, looking at CXCR4 mutations, amongst some other mutations as well, like P53. And you can see, we just go back to the slide. You can see in the right-hand graph in B, graphically, the differences in outcome depending upon mutation status on the right graph.
Sorry, did I go?
Yeah, don't worry.
Do you want me to go? Okay, right.
Go back one, yeah. You just go back
Go
to
back one. Yeah.
So graphically, you can see in B the differences in outcome depending upon mutation status in patients that are treated with ibrutinib. But we feel in the UK that we still need more data to be sure about this, actually. And we're not, so patients who have not got the MYD88 mutation, so patients who've got no mutation at MYD88 could still be prescribed ibrutinib off trial at the moment because we still need more data, actually, to know about this in a bit more detail. So next slide. So this slide shows the schema for the trial. So in the first instance, we need to make sure the diagnosis of WM is confirmed. So that's with an IgM paraprotein and bone marrow involvement. And this trial is for patients that have not been treated before. Then if your doctor thinks you need treatment for your WM, and some of the reasons for needing treatment would include anemia or low blood counts or hyperviscosity or big lumps and bumps or big spleen or neuropathy or many of the different reasons, or even something called amyloid, then once the tick boxes have all been ticked and the patient is deemed eligible, the computer then randomizes the patient between two arms. And we need 74 patients in each arm for the study to be completed. And it's going to be running probably over about 4 years. So in the control arm, the standard treatment is with dexamethasone, cyclophosphamide, and rituximab. And in the ibrutinib arm, rituximab is given in combination with ibrutinib, and you get 8 infusions of rituximab during the study. Once that treatment finishes, ibrutinib continues, and the ibrutinib will continue right up until whether there are side effects that are not being tolerated, or until the WM is not controlled by the ibrutinib any longer. So that could be quite a long time. It could be many years, up to 5 years, maybe even a little bit longer for some patients. And then once the treatment is completed, patients will be followed up every 3 months for a number of years, and to then determine the effectiveness of both treatment arms. And their treatment arms are being compared against each other. Next slide. So these are some of the centres that are participating, and at the moment rollout is still continuing. So COVID stopped some of the centres opening, actually, but centres are coming on board every month, and we expect that there'll probably be about 50 centres that will be signed up to the study. So there should be a centre near most hospitals that is participating in the trial. We're already up to about, I think, 45 patients at the last count. So despite COVID, and lots of centres stopped recruiting during COVID, including ourselves. So despite COVID, we're still above recruitment that we would expect at this stage of the trial. So it's running really well, and yeah, it's recruiting well at the moment.
Can I just ask you a question? Well, not a question, just make a statement, really. I'm absolutely astounded that you've got so many centres involved, and that most of those centres there are ones I've never even heard of, and I'm the patient support manager for WMUK, which is really encouraging that you've got some of those smaller non you know, like Bournemouth and your hospital and Leeds. Yeah, you'd expect those, but there's some really small hospitals on there, and that's really good to see.
Yeah. It's great because not many patients, not many hospitals will have many patients to put into the study, and it takes a lot of time and effort to set up the study. So yeah, we've got a good collaborative network of investigators who are keen to get involved, which is great.
Great.
So the next slide shows what we call the inclusion criteria. So these criteria have to be satisfied to be able to go into the trial. So you'll notice that the first criteria is it has to be a diagnosis of WM, we've just been talking about LPL, with a measurable paraprotein. And it's for patients who've not had any treatment before. And I've listed some of the reasons that you might be considered that you need treatment. And basically able to tolerate the treatment is what we mean by performance status. Next slide. So here I've listed some of the side effects that you might expect. So one of the most talked about side effects with ibrutinib is atrial fibrillation. For this, on the previous trial, so on the original trial by Steve Trean and on the Innovate study, it occurred in between 10 and 11% of patients. It's something that can be managed. So if it does develop on the study, usually you can continue study treatment with ibrutinib, and usually it's managed medically by seeing a cardiologist and giving some medication to treat that. Another common side effect with ibrutinib is blood pressure, a rise in the blood pressure. And I think any patient now that is taking ibrutinib is being encouraged to buy a blood pressure machine and keep an eye on blood pressure at home. Ibrutinib can cause a little bit of a low neutrophil count, white cell count, or a little bit of a low platelet count, but not very often and not to a very severe degree, not to the degree that we see with some forms of chemotherapy like rituximab and bendamustine. Sometimes ibrutinib can cause infections, and sometimes you can get recurrent chest infections, for example, but again, not usually enough to warrant stopping treatment. There can be some troublesome side effects, but generally it's well tolerated and patients usually can remain on treatment. And the last slide.
Oh, I lost my cursor. Hold on. There we go.
Okay. And this is just some of the endpoints that we're looking at. So the main way that we're measuring the different treatments in the trial is called something called progression-free survival. That's the time of treatment free of WM. So that's why we're doing a regular follow-up to see if the protein is remaining stable and to work out the point at which the WM starts to rear its head again. And that for WM is probably the most effective way at telling if one treatment is better than another. Some of the other things we're looking at, which we call secondary endpoints. So some of the other things that we get data on from the trial are the safety, which is very important, the overall response rate, the time to major response. So that's the time to, a huge reduction in paraprotein. We're looking at time to next treatment because that's quite another important endpoint in WM patients. We're looking at how long response lasts. We're looking at complete response. So we know in WM that complete response doesn't happen very often. It's not very often that the paraprotein goes away completely and the bone marrow is completely clear, but we're looking at that on the study. We're looking at overall survival. And I think quite importantly for a study like this, where one of the arms is a fixed duration of treatment for 6 months and the other arm is continuous treatment, we're looking at quality of life. There'll be various time points in which quality of life will be measured. In the lab, we're also looking at some other things. We're looking at different mutations that might be acquired both at the start and during treatment. So we're doing quite extensive mutation analysis on patient samples. And we're also going to be measuring very sensitively blood samples for whether we can find WM samples in the patient's blood, because that's something we did on the R2W study. And that was quite a good way of measuring outcome and response on the study. So those are all the different things that we're measuring. So those are all the slides I've got, and I'm very happy to take questions about this study as well.
So I want to ask, there's a guy on here I know who's done the Rainbow trial. Paul, are you happy to speak? Have you got anything to say? I think you're lurking around there somewhere, Paul. No? Okay. And I know, Sarah, you've probably got a question for Rebecca from the first part of her presentation about the eyes. You come off mute. You're on mute, Sarah. You need to come off of mute.
Yeah, okay.
There you go.
Hi. Yeah, I didn't realise actually that WM affected the eyes at all. And I've learnt to my cost that it does, because I've lost most of the sight in my left eye.
Oh gosh, okay.
So, I mean, I sort of, I don't know what to say. There are very few specialists there around, eye specialists, that really can help you, I think, with this.
Yeah, so I have to say that that sounds. I haven't seen many patients that have completely lost vision, I must say.
Well, I've got a bit left, but it's not much.
Yeah.
Now, I did have a hemorrhage in my right eye earlier in the year, and now I just woke up one morning and my left eye, all I could see was sort of fuzziness.
Oh gosh.
So, yeah, I mean, I'm dealing with it, but it just wasn't something I was expecting. It doesn't sort of appear on the list of things that will happen to you, except it did with yours.
So I think with WM, I think it can affect absolutely any part of the body, to be honest.
Yeah.
From head to toe.
Right.
Cause some quite unusual manifestations. But yeah, eye problems, sort of retinal hemorrhages, and usually they're not. Usually they're quite small, so they're what we call flame-shaped hemorrhages.
Yeah, that's what I had in the right eye. But now I have detached retina as well.
Yes, and sometimes you can get, I think, retinal vein occlusions, which are much more serious, impacting on vision as well from the sticky, thick blood, essentially, as it's running through those tiny vessels.
Yeah,
that's essentially what happens.
I just didn't expect it, but now I've added it to the list of. I mean, so anything can happen to us, really.
Exactly. Yeah.
Okay.
Dave Lee, you've got a question. Dave, take yourself off mute.
Yeah, I just wanted to say that quite recently I've discovered that the WM has affected my clotting. So my von Willebrands has gone to 1.4, I think.
Yeah.
And I was due for cataract surgery, and so we've delayed that. And I'm under Roger Owen at Leeds.
Okay.
And Roger's said, hang on, and I'm going to see the eye specialist at the end of October, and he'll say whether we can wait a little bit longer or whether I need to have a plasma exchange to get rid of a few bits of IgM.
Yeah.
On top of that, I've got the cryoglobulins as well.
Yeah.
And I've got peripheral neuropathy, and I've got sarcoidosis, and I think that's actually caused by the WM, but nobody else nobody will believe me.
You've got lots of the different problems that you can get with it, haven't you? All some and people often don't know about them either. Lots of other doctors don't know about all the different problems that it can cause. This big molecule, this very big IgM molecule that's in the bloodstream and interacting with lots of different proteins and causing, as you say, lots of different problems for you.
I've got a question for you, Rebecca. So the rainbow trial. So I've had my bendamustine and rituximab 6 years ago, so I can't qualify.
No, you can't.
Don't qualify. But if I was a new patient, if I was newly diagnosed, which I'm guessing some people on here may be, and I elected to go on the rainbow trial, would I be allowed to be disappointed if at the point of starting I'm told that I'm going to do DRC rather than the other one, or the other way around, and can I pull out at that point, and is that a big deal?
I mean, if you're perfectly within your rights to pull out of a trial at any point, to be honest. But I think both treatments are really good, so we wouldn't really want to be running the study if we thought one arm was better than the other.
Okay.
So as you know, as doctors, we have to be comfortable that we're offering excellent treatment, irrespective of what the computer says you get randomized to.
Yeah. Okay.
The good thing is that if you do get DRC and then you do need treatment again at some point in the future, you're still eligible for ibrutinib. And actually,
that's right. And Ian Bradley's got a question. If you come off mute.
Okay. I'm currently being treated at Addenbrooke's for LPL. Are there any trials running currently for those of us who haven't progressed yet to WM?
Not specific for LPL, I know of. Sometimes LPL will come under other low-grade non-Hodgkin lymphoma trials. So it could be under studies that are looking at various new options for follicular lymphoma, marginal zone lymphoma, and LPLs are sometimes included in those. Although they're often getting a little bit tighter now with the inclusion criteria, but I'm not sure. We certainly haven't got any specific trials for LPL at Barts at the moment.
So it'd be a case of talking to my consultant, Dr. Follows.
Right. As I say, they usually, LPL would usually come under the umbrella of another indolent lymphoma trial. I don't think there's anything that's running that's specific to LPL on its own.
Okay, thank you.
Dave, you want to ask another question?
Yeah, going back to your first half of your talk, the B cell, when it's immature and before it's matured, does that B cell, besides changing into IgMs, does that B cell change into other things like IgAs or IGGs? Or does that B cell only change into IgMs?
Yeah, good question. So you can get, I've got a couple of patients who've got IgG secreting WM. I haven't seen any with IgA or IgD, but as I say, I have got a couple of patients that have got IgG WM. And then it makes it a little bit more difficult to distinguish it from a condition called myeloma, where those cells do produce IgA, GG, or IgA. But having the MYD88 mutation was really helpful in that case in making sure that we had the right diagnosis, that it was a WM, but secreting a different type of paraprotein from what we would expect. But I haven't, as I say, I haven't seen anyone secrete IgA or IgD. But Roger Rowe might know if there are any, because he's kind of the head of the HNDS at Leeds, so they have a lot of diagnostic samples coming through.
I listened to a talk that Roger Owen gave, and I was a little bit slightly puzzled because he said that the B cell held both the MYD88, which was faulty, and the MYD88, which was not faulty. And so that when you have the BTK inhibitor, I presume that you will inhibit both the bad IgMs and the good IgMs. Is that true?
Yeah, so normal B cells will also be affected by the BTK inhibitor, but to a lesser extent because they are not so reliant on it.
Right, right. So within your body, you could still have some good IgMs.
Yeah.
Because the function of the IgM, I presume, is to fight infection.
Yeah, so you'll have some normal IgM produced as well as the abnormal that's produced by the WM cells, essentially. Yes, you're right. Yeah.
Right. Yeah.
So anyway, Paul Davey, who wants to ask a question, but I want to ask him a question anyway first, because he didn't appear just now, is he's been on the Rainbow trial. I think I'm right in saying. No, he hasn't. Okay, all right, I'll forget that. What's your question, Paul?
Sorry, Bob. No, I haven't. I was on DRC last year and had an excellent response to treatment. My question, Rebecca, hello, really informative. Thanks for your time. My question is it possible to have free light chain only WM, whereby the IgM level that you were diagnosed with was almost normal, but your free light chains are off the scale? Or would that perhaps be more LPL?
Yes, I think you probably could get that. So sometimes we, so I'm not a myeloma doctor, I'm a lymphoma doctor, but so in the myeloma setting, they're always measuring serum free light chains in the blood, but the expectation is that they would be raised in WM as well. And it's the IgM is a bit odd because in some patients it can be quite low. It can only be, it can be less than 10, but still have quite heavy bone marrow infiltration with IgM and problems from it as well. So this IgM can be a bit of a poor correlate really of what's going on in the bone marrow. So it can still be that you have, quite a lot of problems with WM, but have quite a low level of IgM circulating. A bit odd sometimes.
Yeah, no, thank you, because that's
yes.
kind of my situation, and I haven't really heard of anybody in that similar situation. I've got everything else that we ticked on the list of symptoms, etc. last year, but IgM seemed to be normal, but free light chains were 1300 or something ridiculous. But treatment was excellent, so treated the same. But I just wondered really, because I hadn't heard about anybody else being in the same bracket. Interesting. Thanks.
Thank you for that. I'm going to. We're running out of time, and Rebecca's given us an hour of her time already. But I'm going to go to William, because I think he's the guy I'm thinking about who's been on the Rainbow trial. I haven't got a question for you, William. I just wanted to know if you had a comment on what it was like being on the Rainbow trial.
Fine. So yes, I am on the Rainbow trial, as you say. So I started my treatment on the 1st of July. So that was obviously the first round of rituximab infusions, which I had for 4 weeks. My second round starts later this month again, weekly infusions. And since the 1st of July, I've been on ibrutinib, which was going great guns until my September blood tests, which showed a real spike in my liver enzymes. So they went from a normal range up to 375. So I had to stop taking ibrutinib. I kept on the antiviral drugs that you're prescribed at the same time, so I continued on those. And I had blood tests last week where they have reduced down to about 90. So it's come off by about, whatever that is, 2/3, 3/4. And I've restarted on a lower dose. So I'm taking 280 milligrams instead of the 420. And hopefully that will work, but I will find out my tolerance to that, and whether my enzyme levels remain at an acceptable level. So what has that meant for me? Well, as soon as I came off the ibrutinib, the old fatigue kicked back in big time. Was the most noticeable thing that I found. So that's really been my experience to date. So for 10 weeks it was going great, but as soon as I came off the ibrutinib, I was amazed how quickly that fatigue symptom came back and got me, because that's only it's only 3.5 weeks ago.
Thanks for that, William. And Rebecca, have you got a generic sort of comment to make about that?
Well, hopefully the liver will get, it will settle and it won't recur again, because I think it's quite unlucky. We don't often run into liver problems with ibrutinib. I've treated a lot of people with ibrutinib, irrespective of whether they've got WM, other hematological malignancies, and don't often see problems with the liver. So hopefully that will settle down for you, and you can get back. We do see, when ibrutinib is stopped in WM patients, we do see the protein can start going up again quite quickly, and those symptoms come back quite quickly. Seems to be putting a lid on it without, obliterating out the bone marrow completely.
Thanks, Rebecca. If you don't mind, I'm going to take one more question, and it's from Alaska. Can you believe?
Yeah. Thank you, Rebecca. A quick question. I realise it's early days with the Rainbow trial, but could you explain how the sort of progression of your treatment response might compare to a more classical chemo style treatment? With the chemo treatments, over a set number of months, you have a certain number of doses. You watch your IgM go down, hopefully, and then because the rituximab has a longer sort of half-life, perhaps 3 to 6 months after you stop, the IgM may go down a little further. How does it work with people who are on the BTK inhibitors? You know, presumably while they're doing the rituximab, you see something similar, but does it take longer for your IgM to drift down to ultimately where it may go to, or,
Yes.
or don't we know yet?
Yeah, I think you're right in that. It does take longer. I think you start to feel better quickly, but to get it right down, you know, it does. I think we will see it taking longer. And it's, as I say, it's a little bit of a different way of looking at it, because we're more putting a lid on it rather than, you know, eradicating it out of the body, because we know it does. Well, we don't know yet how long we can. Some of the hematological malignancies, we're actually being allowed to stop the ibrutinib. Say after about 8 years in CLL patients, we are comfortable to stop it, but we haven't got yet that data for WM. So hopefully this trial will inform us about, you know, how deep a response we can get with ibrutinib, and whether eventually we can stop it as well. But yes, you're absolutely right.
Thank you. So, Rebecca, thank you so much. Guys, we're going to be seeing Rebecca again on the 13th of November, when she's going to do a talk with Jamal Kathari on clinical trials, which we're looking forward to. Rebecca, thank you so much for joining us tonight. I appreciate you giving up so much of your free time. Really, really appreciate that, and I'm sure the guys do as well. Any technical problems tonight were my fault, not Rebecca's. I'm sorry about that. And if you didn't get a chance to ask a question, I apologise for that also. Hazel, it's nice to see the dog on your lap again. We're seeing that dog every time now, which is good. Ronald, it's great to see you up there in Scotland, still not saying anything, which is good. And guys, thank you so much. Rebecca, thank you so much. And don't forget, guys, on Thursday, we've got Shirley Dessart and Professor Mike Lunn, who are going to be talking about peripheral neuropathy, which is going to be a massive webinar, well attended. So if you've got a question, get it into me on my email address before Thursday, and I'll try and get it into the session. So without further ado, I'll say good night to you all, and thank you very much. Rebecca, thank you. See you soon.
Bye-bye.
Thank you,
Bye-bye.
Everybody. Bye-bye.
Bye-bye.
Thanks, everyone.